Welcome everyone to tonight's webinar. We are really excited to bring this topic to you. And the title, of course, is Intensive Therapy for Pediatric Populations. Can LSVT really work? And hopefully by the end of this webinar tonight, you'll have a solid answer to that question. And just so excited to bring to you our panelists for tonight's webinar. By the way, my name is Laura Gousset. I am an LSVT BIG certification faculty and Chief Clinical Officer of LSVT BIG, but in tonight's role, I will be serving as your webinar moderator. I'm joined by Dr. Cynthia Fox, the co-founder and CEO of LSVT Global, who is waving at you now, and she was really instrumental in the development and research of LSVT LOUD for kids. And so excited to have her share her story tonight about, how this all got started. After her, we'll introduce you to Dusty Tolley, a fellow physical therapist and LSVT BIG certified clinician who has begun to offer LSVT BIG to some of his pediatric clients. And he has a case study that he'll be sharing with you tonight. And I think you'll really love to see the videos in that. Next up will be Dr. Jessica Galgano, and Jessica is also one of our LSVT LOUD training and certification faculty. She's waving at you right now live from New York City, so we might hear some sirens tonight. You never know what you might hear in the background, but that'll be exciting. And Jessica has a private practice called Open Lines Communication in New York City and has done just a ton of work with children and also using LSVT LOUD with pediatric clients. And she has a very interesting case that I personally can't wait to hear about tonight. And last but certainly not least is Jennifer Gray, a speech language pathologist and owner and operator of Gray's Peak Speech Therapy Services. And she will be talking to you about the use of LSVT LOUD for clients, not only children, but also adults with Down syndrome and speech and voice disorders related to that. So I won't read our bios here for you, but they are here if you need them for CEU purposes. They're on your handouts printed out, and each of the panelists will introduce themselves a little bit more in depth, better than I did, as they start their own section of presentation. Some brief disclosures. We do announce that we have both financial and non-financial relationships, including a preference for LSVT LOUD and LSVT BIG as treatment techniques. Dr. Tolley and Ms. Gray were offered honorarium for their time and expert knowledge that they're so graciously giving us tonight and giving you. Dr. Galgano is a consultant for LSVT Global, and I myself am an employee of LSVT Global, and we receive lecture honorarium. Dr. Fox is an employee of and has ownership interest in LSVT Global as well. Just a few logistics. Right now, all of your microphones should be muted just to make sure there's no background noise for your environments. If your microphone comes unmuted, we just ask you kindly to keep it muted, just so there's no distractions for the other attendees or for the presenters on tonight's webinar. But we will give you an opportunity to ask as many questions as you can think of on this topic during the webinar. You can type in your questions into the chat box on your control panel at any time. We will stockpile those. Some of them we might choose to address as we go along. As the presenter presents that content, you might have some really on-the-spot relevant questions that we want to address right then and there. But we do plan to have at least 15 minutes of Q&A time at the end to address as many of your questions as we can. So please don't feel shy about using that chat panel. I myself and Dr. Fox will be monitoring it throughout the night. There are handouts that have been emailed to you prior to the webinar. If you did not receive a handout for this webinar, you can email webinars@lsvtglobal.com to request a handout, but we typically do email one after the webinar as well when we provide you with your certificate. You also receive an email with a link to a survey. We just really appreciate you answering that survey. It's really short, just tells us about how we did, how the technology was, and we would love to know your ideas for future webinars as well. Some brief information on self-reported CE activity. If you're a speech language pathologist, physical or therapy or occupational therapy professional joining us today, just note that these are not ASHA state registered or pre-approved for CEUs for speech, PT, and OT professionals, but you can use them as self-reported CE credits, and many states do allow for that. So if you would like us to give you a certificate, we can certainly do that as long as you attend for the full 90-minute webinar. You can email webinars@lsvtglobal.com. If you're not sure about your state accepting self-reported CEU activity, the best thing is to just contact them and ask your state board. If you happen to be watching this webinar on demand at a later time, please email us at webinars@lsvtglobal.com for instructions on how to request a CE certificate for this course. Just a friendly reminder, we have a lot of really, really wonderful videos of children and adults throughout this presentation, and the clients shown or their parents or guardians have given consent for these videos to be shown for educational purposes, but we really want to protect their privacy as much as possible. So even though they're very engaging videos, we ask kindly that you don't screen capture, screen share, record the videos, anything like that, just to protect their privacy. In terms of learning objectives, 3 really brief ones: define the rationale for using LSVT therapies in the pediatric populations, highlight outcome data from 2 case studies of LSVT LOUD or LSVT BIG in pediatric populations, and summarize that decision-making process for determining suitability of pediatric clients for LSVT LOUD or LSVT BIG. And I know for many of you who are LSVT certified, that's a big question, right? Is how do I know if they would be appropriate clients and really good responders to these interventions? So speaking of that, before I turn it over to Dr. Fox, we really would love to know who is joining us tonight. So, and this will get your fingers used to typing in the chat panel as well. So if you could just enter in what your discipline is, if you are a therapist, if you're an SLP, PT, OT, PTA, OTA, that kind of thing, maybe you're a student, let us know. If you're not a healthcare professional, maybe type in who you are. You don't have to go by name, but if you are a person, maybe a parent, or maybe you are an adult dealing with some sort of neurological condition, whatever it is, we want to know who you are. And let's see, I think we've got some coming in right now. So really looks like a really wonderful blend of all 3 disciplines of PT, OT, and speech. So really great to see that. Some students, yay, Columbia University. Great, maybe some people from different countries. That's wonderful to see that tonight. Okay, one more question. We would like to know, do you currently work with kids in your practice if you're a healthcare professional? So simple, yes, I do, or no, I don't. A lot of yeses, and that would make sense why you would be interested in this webinar. But for those of you that say no, I think after this webinar, you might just want to change your practice. No, just kidding. They're very, very sweet. Okay, great. So with that, I am going to turn the spotlight over to Dr. Fox, and she is going to walk you through how we got here with LSVT LOUD and LSVT BIG, moving from Parkinson's to pediatrics.
Awesome. Well, welcome everybody. It's great to have you here with us tonight. Let me just fix my control there. And I'm Cynthia, and I have been with LSVT and doing LSVT since 1994. And so my clinical fellowship was actually doing some of the efficacy research in the Parkinson population. I've continued on a research path, but also clinical faculty for training courses, and did some of the initial work in the translation of Parkinson's to pediatrics and the use of LSVT LOUD. So I just wanted to start with kind of how did this happen? And why would we ever think that a Parkinson's treatment would extend? First of all, it's neurodegenerative, it's in adults, to pediatric and developing populations. And the story goes like this. I was at the University of Arizona here in Tucson, where I still am today in Tucson, Arizona, and working on my PhD. At that time, I was in a lab, a respiratory lab in the speech and hearing sciences department. It was the Hoyt-Hickson lab. And one of the individuals working there, Dr. Carol Bullock, was studying speech breathing patterns and behaviors, both in infants at risk for cerebral palsy and a cross-sectional study of children with cerebral palsy. And as happens in these types of learning environments, we talk a lot about, oh, what are you doing? What's your research? What are you doing? What's your research? And over time, Carol and I, talked a lot about, wow, these kids, so many of them have, poor respiratory support, poor respiratory laryngeal coordination. And the idea sort of began to bud that maybe LSVT could be a treatment that for select children might be beneficial. Well, I'll never forget the day she came to me and she goes, I've got the kiddo, let's give it a try. And sounded good theoretically, but I haven't worked with kids in years. And I was like, okay, let's give it a try. And literally, we had no idea, would a child do these exercises? Would a child go for as long as they can and do that 15, 20, 25 repetitions? And in all honesty, my initial assumption was probably not. But we did it. We did some trial stimulability testing in this little guy. He did great. Mom was all in for trial treatment. We did a week of treatment and the outcomes were impressive and they were motivating to us. So if we go to the next slide, these are some data from this little guy. So on the left-hand side, he is saying the phrase, I don't know, before treatment. And what you see there is a microphone signal and the spectrogram. And then on the right-hand side, we see that same phrase, I don't know, after treatment. And so Laura is going to play these for us now. We'll just listen one more time to that. Whoops. And now post-treatment.
I don't know. I don't know.
So we were intrigued. We hear things that are similar to our adults. The source and that sort of foundation of loudness improved, but we also got some of that carryover to articulation. And so this really served as a pilot project for what then became my dissertation work in an additional 5 children with predominantly spastic type cerebral palsy. And then that has led to now nearly 20 years worth of investigation to where we're at a point in particular with LSVT LOUD that we think we have something to share. So let me give you a broader perspective of the LSVT treatment concepts and why we might think they would apply. Those of you who are already certified know these concepts well. If you're new to LSVT, these are our key essential concepts. Our target is amplitude. In the speech mechanism, that's vocal loudness. In the body, that's bigger movements. The mode of delivery is intensive and high effort. And we have a concept called calibration, which addresses barriers to generalization out beyond the treatment room. So let's start with the target of treatment, amplitude, vocal loudness, bigger movements. Why would that be a target? And when we think about amplitude, we can think of it in 2 ways. The first way is a source and the second way is a trigger. And this really comes from our research in Parkinson's that carries over. So if we look at this chart here, hypokinetic types of movement disorders is where LSVT began. That's classic Parkinson disease, where you have reduced amplitude of output. So this results, for example, in a soft, monotone voice, small, slow movements. So the rationale for LSVT is clear. We're using loud and big to override that bradykinesia, hypokinesia, increase the amplitude of output to improve things like loudness and the size and speed of movements. When we step away from Parkinson disease, what's that rationale for focusing on amplitude? Well, if we look at something like a spastic type of movement disorder that may be secondary to stroke or cerebral palsy, oftentimes across the limb and speech, we have weakness, maybe limited range of motion, tightness or stiffness in muscles. In this case, we're driving healthy normal amplitude as a way to improve loudness, build strength, build range of motion, oftentimes as well to decrease perhaps some bad compensatory behaviors. Moving on to ataxia, here with ataxia, we have variability, right? Things are too loud, too big, too small, too soft. There's incoordination. And this one intuitively, people are like, why would you drive loud or big? Well, again, our target is always normal loudness, normal bigness. If you're hypokinetic, yes, you're upscaling that output. But for these other disorders, it's really about stabilization and being able to modulate normal loudness, normal healthy amplitude. And finally, you might think of something like flaccid type of movement disorder, where again, you've got some weakness, some low tone. We're driving amplitude to improve strength and coordination. So that's just a way to kind of put on your amplitude thinking hat about how LSVT may apply, but it also serves as a trigger. So when we train and shape normal loudness or healthy vocal quality and normal amplitude movement with healthy quality, it can also impact other elements of speech. For example, this would be breath support, mouth opening, intonation, articulation, rate, facial expressions, naturalness. We've documented all of this very extensively in Parkinson's. And in terms of movement, things like trunk rotation, stride length, speed, balance, coordination, activities of daily living. So this concept of a source and trigger really can work to provide efficient treatment for some of these diagnoses. In terms of mode of delivery, LSVT is intensive and high effort. 4 days a week for 4 weeks, 60-minute individual treatment sessions. Why? Well, we know that treatment-dependent neuroplasticity in pediatric context occurs, next slide, when we have intensive task repetitions. We have progressive challenges to the learner with increasing difficulty. There's presence of motivators and rewards, especially when they're internally driven. It's active participation. We're working on skill acquisition of a very functional goal, and the practice must be structured. And so you could not write a better sort of textbook for the way both LSVT LOUD and LSVT BIG were developed and delivered to incorporate all of these. And as such, our goal in therapy, next slide, is to incorporate these multiple repetitions that drive plasticity. And we certainly do. LSVT treatments are intensive. We have building complexity. We incorporate multiple repetitions. There's always salience of activities, which allows for individualization. The timing of the treatment may matter, and we have specificity of practice. So the third essential concept is called calibration. And again, calibration addresses barriers to generalization. In Parkinson disease, it's very specific to some of the non-motor symptoms, the sensory challenges, neuropsychological challenges, internal cueing. But it also bears out that it's important in pediatric populations. So why? Well, our goal with our treatment, next slide, is that the child automatically uses improved voice or movements in daily living, and those improvements last over time. LSVT therapies are not just these sets of exercises. That's one tiny component of the treatment. The more important components of treatment is how we translate those exercises into function. And we do that by having salient activities. We have individualized functional phrases in speech, functional component tasks in BIG. We build progressive hierarchies of specific individualized goals, and we all have very specific carryover exercises. So with that, let's take a look at this video. This is a little girl with cerebral palsy. She is towards the end of her treatment. So this is week 4, but it just gives you a little example of the LSVT therapy in a pediatric population. Oh, perfect, Miss Katie. So what we're gonna do is you're gonna give me a nice big ah, ah. Whoa! What did you get?
I got 953.
Good. Are you ready with your big, beautiful voice?
Yes.
Okay.
Hello, this is Katie.
Perfect.
Good morning. Stop it. Okay. Yes, please.
Don't forget to breathe.
Mom, Dad, come in here. Can I wake up? Stacy, thank you. Excuse me.
Okay, what if they didn't hear?
Excuse me.
Good. All right, now with your ah, let me hear another little ah. Go ah.
Ah,
Good with that voice. Explain what that is.
this is something you cook with. And it has different buttons that you can push.
Oh, try that again.
It has different buttons that you can push.
Good.
Microwave.
No.
No. Stove.
Yes.
Woo! Good. Okay, so that's just a little example again of the exercises and how we take that, for example, that good ah and that good amplitude and train it systematically into speech. Now, we have completed a number of phase 1 and phase 2 trials in both children with cerebral palsy and Down syndrome. I won't be going through this research tonight because this is really a kind of a case-based type of presentation, but I will give you an overview, and certainly you see the QR code on your handout. You can scan that to get to our publications and see the full list. But we've done, the top study was my dissertation work where we had a single subject, multiple baseline design, children with cerebral palsy, 5 to 7 years. And we looked at things like parent ratings, listener perceptions, and acoustic outcomes. Similarly, a study, children with Down syndrome, 4 to 8 years, 9 participants, those same measures, that was just published this year. Then we started to expand, and this is where Dr. Bullock really took over at the University of Alberta in Edmonton, Canada, and did a second cohort control, bigger age range, 6 to 10 years old, and comparative, both children with cerebral palsy and typical developing, those same parent ratings, listener perception, and acoustics, but added physiology, so things like chest wall, EMG, as well as speech, breathing, kinematics, and imaging. And in this cohort, they had DTI imaging, so diffuser attention imaging. Then another cohort, again, expanding that age range to more school age, 8 to 16 years old, another 9 children, also imaging, adding functional MRI. So it's a beautiful, detailed data set that looks at so many levels of functioning to really help us understand the hows and whys of LSVT loud in these children. So hopefully you'll, as soon as we're done, scan that code and start reading tonight, all the exciting research. But with that, I will stop with my introduction and overview with cerebral palsy. And I believe I'll turn it back over to Laura, who will
All right.
introduce us to Dusty.
Okay. All right. Well, thank you, Cynthia, for that really wonderful overview in a very short amount of time. And the research really is fascinating. So I would recommend that you, if you're interested, to take some time and do read it. Dusty, I see you, and I'm just going to spotlight you here so everyone can see you. And I'm going to move to the next slide. But before we start, Dusty, I think everyone would love to know a little bit about who you are, where you live, kind of a little bit about your practice and how you got here in terms of beginning to think about providing LSVT BIG to your pediatric clients. So I'll turn it over to you. Yep.
Thank you. I'm really honored and excited to share this case with you. I was actually really enjoying Dr. Fox's commentary there. I live in LSVT BIG world, so getting to hear all about LOUD is fascinating. I started my career in outpatient orthopedics, and I was there for about 5 years. I had 2 colleagues that went on to do their LSVT BIG certifications. And after about 5 years in outpatient ortho, which I liked, my wife convinced me that I was being wasted there, and I was actually a secret pediatric physical therapist and didn't know that. She is a pediatric occupational therapist. She's phenomenal, and she's very smart, and she knew exactly what she was doing because that's where I was meant to be, and I love it. We live in Charleston, South Carolina. We own Holy City Pediatric Therapy, that is a multidiscipline PT, OT, and speech clinic, and we see birth to about 21. I would say mostly our caseload is from about 2 to 10 years old. And we started an intensive program, and LSVT is one of our intensives that we offer. And so how I decided the LSVT BIG is where I needed to go was I had this patient that you guys will get to meet shortly. And she had a very complex pathology and something that I had been with her through several different bouts. And one night after her session, I was sitting in my office and I was kind of frustrated because we were building strength and we were getting range of motion and we were doing all the good things, but it wasn't carrying over functionally. She was 9 years old at the time, and she was using an assistive device and wanted to get back to playing with her friends and all of the things and the stigmas that were attached to her assistive device. And she wanted to break those chains a little bit. And, you know, I was pouring everything I had into her, and we just weren't getting there. And so I just listed all of her symptoms down on a blank sheet of paper and sat there and looked at it. And I thought, if I was not a pediatric therapist, if this patient was not 9 years old, what would I do? And I thought back as I looked at some of the things, the ataxia, the gait abnormalities, the freezing every now and then. And I thought, if she was older in my outpatient ortho, I would refer her over to one of my LSVT BIG colleagues. And so I called her mom and I said, I have an idea. And she ran it up the chain with their oncology rehab team. And they said, this sounds great, let's try it. And I said, cool. So then I went and got BIG certified, and we went into this intensive, and you'll get to see the videos. She's amazing. She's such a great patient, and we get to see some really good results here as we go. So I'll introduce her a little bit here. At the time of this intensive, she was a 10-year-old female. She was diagnosed with anaplastic epidermoma. It was a grade 3 brain cancer. She had been diagnosed 5 years prior, and her tumor was in her 4th ventricle in the cerebellum. She had had 3 open brain surgeries for the tumor removal and 50 doses of targeted radiation. So this is why that we chose LSVT. The traditional therapies had improved her strength, but again, that functional independence just wasn't there. This was a girl who had all of her independence and was moving through those developmental milestones as appropriate, and then that independence was taken away from her. Things as simple as going to the bathroom on her own were something that she missed and she needed assistance for now. And so that became one of our big motivators and one of our end goals that we wanted to do. So what we did was a pre-assessment. We used some orthopedic type measures. We did the LSVT BIG intensive just as prescribed, 4 sessions per week times 4 weeks. And then the big exercises, homeworks were conducted by her parents at home. And we had really, really high parent buy-in. Her parents were phenomenal in this. And you'll see the post-assessment in a little bit. So for our baseline testing, we used a 30-second sit-stand test and a floor to stand. One of her big complaints was that she loved to get on the floor and play with her dog, and she couldn't get up afterwards. It was something that was real relaxing to her, and we wanted to give her back that independence. And so floor to stand was important for us. The 6-minute walk test using her assistive devices, she kind of rotated back and forth between an anterior ETAC type walker, and then she also had a posterior pediatric walker. But she preferred the anterior walker, and I think a little bit of that was in the land of COVID. She said that it made sure that she had social distancing at all times. And so we'll get to see her 30-second sit to stand right here. One, as many as you can do. Two, good. 3, 4, 5, 6. That's good. Go. Perfect. There we go. Most of us work in pediatrics. You can probably appreciate the background noise there. So we had 6 reps on the 30-second sit to stand, and then our floor to stand was 7 seconds. And then our 6-minute walk test was 800 feet using her assistive device. Initially, we had to make some modifications. Her balance just wasn't fully there to be able to support herself initially. And so we used a bar to get a little bit of balance support in that first week. And then we were able to remove that at day 6. And then one thing that I've always done and something that we really use with this type of intensive is to give the kids as much ownership as possible within their treatment parameters. And so it kind of started out as a joke, but then we ended up renaming all of these exercises to something that she preferred. You'll get to see a little bit of this exercise as we kind of modified it here.
Open.
Big steps.
Open.
Good.
Open. Open. Back. Good job.
All right, towards me. So she renamed all of these exercises and it made it fun. And to be honest, I still call them this sometimes. My favorite is the side-to-side seated exercises. She named those big scoops, and every single day we were scooping something different. Usually it was some sort of sweets. We really love sweets. So some days it would be ice cream and chocolate chips as we scooped our big scoops. And I don't have a video of those exercises, but if you can look those up. We scoop as we sit to get that trunk rotation side to side. On her really bad days, we were scooping manure and different things that she would bring in to tell me to scoop. But she had so much fun with that. We just called the front steps front, called the back steps back. The sideways steps, you kind of come out. And she likes the show New Girl, and she would call those New Girls. It's like, who's that girl? Here she is. She hated the rock and reach exercises. These were very, very, very tough for her. This is the most dynamic of the exercises in standing. And so she called them the worst and almost the worst. And I would ask her, which ones do you want to do now? And she's like, oh, let's do almost the worst. And so, but we had fun with it. I feel like I got to go home and think about it, and then come in the next day and ask her parents, how did it go? And her parents would say, she's doing a lot better with new girls, but she still hates the worst. And so it was great that she named this, she owned this, and this kind of got more buy-in, I feel like, for her. So we also worked some functional practice examples. We wanted to be able to step up onto stairs, on curbs, negotiate that kind of thing. Sit to stands were very tough for her. She renamed these Wonder Womans because she got to stand up with authority. We worked on big walking a great deal. And then her hierarchical skill was navigating in and out of the bathroom. And we had a restroom on site that we would try to practice independent negotiation, going in and out, standing up, without actually performing the tasks. But for her to go in, do her thing, come back out, and do it safely. And so that was our big skill that she really wanted to get to. That was where she was reaching for. So in determining that we wanted LSVT big, the big thing that we wanted to get out of this was not just strength, because we had been building strength, but we had not been building power, the strength over a small duration of time. And that's where she lacked. And in other words, she lacked the amplitude, the big movements quickly. And so after our 4-week intensive, we got to look at her sit to standing in, and you can see the difference side by side here. So what a difference in real time there, side by side. My favorite part of this video is that in the course of this, we saw her confidence build day to day. And so if you can see, she went and she got her hair did, she got some new clothes, and she's so much more confident in this. And her shoulders are back. We saw her start projecting her voice a little bit better. And those are all the things that were not measurable in what we were doing here, but we were really pleased with the change. And again, floor to stand was really important. We wanted her to be able to do functional tasks on the floor with her dog and with other people, and then be able to get up, because that's going to be a huge deterrent in being able to do the things that she loves if she can't complete it. So here's the difference after our LSVT big intensive.
Ready, set, go.
I was so proud of that one. That was actually her second take on that one, because I missed it the first time. My thumb wasn't fast enough to get a good video. So so proud of how well she did with that one. And she told me that Frankie the dog was impressed as well when she got home.
Ready?
So just looking at our different parameters that we measured before and after, her 6-minute walk test went from 800 feet to 1,007 feet. And she was using the assistive device in the beginning, and in the end, she was not. So that's a huge change, 207 feet without an assistive device. It ends at 25.9% improvement. We use we call it the BOT 2 for our percentile ranks. We did it before and after. And so she went from the first percentile rank in body coordination and strength and agility into, she went from the first to the 5th percentile in both of those. And then we saw her develop single leg stance for the first time in years. She had 0 in both legs prior to this. Tandem stance went from 0 to 14 and 17. And we still were using the ETAC walker for longer distances of ambulation. And when she was on different surfaces, her playground with kids was outside on lots of different surfaces. So she used the ETAC out there for safety, but she stopped using it along the in the school.
All right. Well, Dusty, I just want to say a huge thank you. I've seen that case a few times now, and it brings me the same joy every time I see it to see her and, hear you talk about her and all of the qualitative improvements that she made in her life too. I think, like you say, are really, really important. So thank you for that. And if you have questions for Dusty, please put them in the chat and we'll answer them at the end of our webinar tonight during our Q&A time. So next up is going to be Dr. Galgano, and I'm just trying to find you right now, Jessica. Let's see, I think there you are.
Hi, Laura.
All right.
Can you see and hear me?
Yes, and I have spotlighted you. And I think I'm going to advance the slide and
Terrific.
kick it over to you. So tell us a little bit about you, where you practice, how you got into working with pediatrics and LSVT LOUD.
Sure. Well, my name is Dr. Jessica Galgano, and I've been administering LSVT LOUD to people with Parkinson's and to children with a wide variety of neurological diagnoses for many years. In fact, I've been working with LSVT LOUD for over 20. And so I have really found LSVT LOUD to be one of the most valuable treatment programs out there for me. It's really continuously informed and it's transformed my clinical practice with each one of the patients that I see, whether a child or adult, in the offices that I run in New York City and Los Angeles. So I act as one of LSVT LOUD's clinical experts, and I've been an LSVT LOUD faculty instructor for almost 13 years now. And I'm excited tonight to report out to everyone about a really interesting case. It was published last year as a brief report, and it involves a child with autism who completed the LSVT LOUD program, but did need treatment prior to being able to complete the intensive and prepare him to be able to fully participate. So let's take a look and dig in a little bit more. So at the time that this child was brought into my office, he was 16 and a half, actually. But we were not able to do the LSVT LOUD program until he was 18. And so that was the situation with him. What was really interesting about him, let me start off by telling you a little bit about his background. He had a diagnosis of autism spectrum disorder. He was diagnosed with cognitive communication, speech motor, and language disorders. He had a fluency issue. He also was diagnosed with dysarthria and childhood apraxia of speech. He was not on medications, and his parent did report a number of speech and voice concerns. Specifically, she talked about weak breath control, reduced loudness, or that hypophonia. We hear as speech pathologists, which might kind of indicate or prompt us to think about increasing amplitude and thinking about LSVT LOUD. He had a very limited clarity or limited speech intelligibility when he attempted to speak. He did not appear to have enough breath. He had soft speech. He was monotone, and he didn't have any confidence when speaking, which I think is a really important point that many of our families report when they're bringing the kids in. So I moved forward with an assessment, and we conducted stimulability testing for LSVT LOUD at that time. But assessment results revealed that he was not stimulable for LSVT LOUD. And so there were a number of negative prognostic variables. At the time of the assessment, he was not able to respond to cues or models to increase loudness. He was younger at the time, and it was difficult for him to follow the tasks, follow directions, even respond to the model that was being provided. He did have a number of behavioral problems as well, and that did interrupt how much we could get done in a session. And so there were a number of variables that led me to state at the time that he was not a candidate for the LSVT LOUD program. However, the parent was not hearing that. And so some of the positive prognostic variables was the level of motivation that this family had. Boy, they had tried everything over the past 16 years that the child was in therapy, and they really wanted to try something new. So they were really motivated to attempt to acquire functional verbal communication. And what I wanted to do, I didn't want to jump into the intensive. I didn't want to get them excited for something that I just wasn't sure if it would work. And so I talked with them about a trial week of treatment to determine candidacy and feasibility. And we talked about adding this child's behavioral therapist to co-treat to better manage behavior during the sessions and improve participation. So, how could I say no? So, and when we asked this child about his thoughts about speech therapy and trying this program, especially considering that it was so intensive compared to what he had done in the past, he used augmentative and alternative communication to state that he wanted to find his ability to start and carry full conversations, and that was his intent for the future. And so he was motivated. So I thought, okay, team, let's do this. And so we moved on. So I couldn't jump into the intensive protocol right away. And so what we ended up doing was everything we could to prepare him to become, to be able to fully participate in that 1 hour session 4 times per week for a full month. So in the first 6 months, what we did was we established a response to multisensory models, and we faded cues along the way. So over time, what we had to do was train his ability to respond to the model. He was not able to take that nice deep breath in and project that ah out. And so we spent quite a bit of time just helping him understand that he had the ability to take a deep breath in. One of the things that we did was we just put some tactile pressure, a little light pressure or a tactile cue on his stomach, and gave him that feedback as he was exhaling, and the stomach was kind of going down a little bit. And then as he reached the end of that cycle, we then gave him that cue for loudness and showed him how he was taking that deep breath in, and from there trained volitional exhalation. Over time, we deepened that inhalation. We trained his ability to sustain exhalation versus just breathe it all out all at once. And then we paired that sustained controlled exhalation of air with phonation. Then over time, we built a tolerance for repetitive practice. And that behavioral therapist was so important, really helped me and helped the child manage and regulate behavior during that session and establish behavioral supports that we needed along the way. And so that took us a good 6 months to be able to establish that response to the multisensory model that I knew we would need during the intensive protocol. And then we moved to a second, so now I'm going to show you a little video of this beginning stage. And so what you're going to see here is this child. We were in the park at the time, and there's on the table that is in front of him, there is a piece of paper and a line. And so I'm in front of him. You'll hear me breathe, and the behavioral therapist is next to him, helping him use the tactile cue to sustain phonation with the ah. So let's take a look.
Wait a second. 1, 2.
Excellent. So Laura, let's play it just one more time because that voice is quiet.
Wait a second. 1, 2.
All right, so you hear that phonation. It's a couple of seconds long. Mandibular excursion or open mouth is not too much, that sound is quiet, but we've got it. And he was able to start to control that. So that was really the very beginning of this, when this child was learning to perform the exercise. And then we shifted to what I called stage 2 of the pre-treatment protocol. And this is where we really built this child's ability to have the stamina to complete all of the exercises, all of the first exercise and the second daily exercise. So we stabilized that normally loud phonation. We built loudness, we stabilized it. We then helped him to extend that phonation. And then we started to teach pitch manipulation to be able to go from modal pitch to a higher pitch or modal to low while maintaining that normal loudness and healthy voice quality. And I must say that that high exercise, the highs and the lows, was the trickiest for this child and remained just as tricky through the intensive protocol. So then we moved on to stage 3. And so we were a year in at this point, but this family, this child, the behavioral therapist, the parent, they were not giving up. They were seeing this progress. They were excited. And so we kept going and we established a competency in his ability to perform all the aspects of LSVT LOUD in 1 hour. So we developed an endurance. We developed those functional phrases that we were being prepared to do 5 times within the intensive protocol. And then we implemented a scaled up, that scaled up loudness, that normal loudness level into hierarchy. So we were ready to kind of bring that voice into speech a little bit. And so I thought at that point, 18 months in, okay, now we have made it. And so we were able to, he was stimulable for LSVT LOUD, and we were able to administer the full LSVT LOUD gold standard protocol and deliver the entire intensive. So it was very exciting. Interestingly, this child benefited across the 4 weeks, and then I added some additional weeks for him because he was doing so well, and we were working to work on cognitive communication and language as well. But overall, he made great gains across many perceptual and acoustic measures during performance tasks. His maximum phonation time increased, and that's important because for those of you who are PTs and OTs and may not work with speech, to be able to sustain phonation for a longer period of time with normal loudness allows for a more complete thought. And so what I've seen in practice with these kiddos is that, because many times the school districts, if they're not able to do the intensive program, they'll send the kids over to us during the summer or a break to get the intensive protocol. And the speech pathologists at school will call us and say, hey, we've seen a great bump in the language. Thank you. We're going to take it from here. And what we're thinking is, gosh, this child can actually now take the breath in, produce the voice with normal loudness, and sustain enough to be able to express all of that expressive language that's up there. So it's been very exciting to see. With this child, his loudness improved, speech intelligibility improved. So we really saw that spreading of the effect you get when you increase amplitude of movement across the entire motor speech system. For this one, there was variability due to behavior. Speech and language disorder was noted and did limit our ability to advance into more complex reading and conversational levels due to those language difficulties, but those adaptations were easy to make. Improvements were maintained at the 5-month time point. And beautifully, I loved seeing this as just kind of a surprise result. The disfluencies that were noted and that contributed to unintelligibility were absent in post-testing and follow-up. So let's take a look at one of the videos of this child doing the functional phrases during the intensive protocol. Sorry, this was the off. So he's grown up a little bit, but look at that smile. Great loudness and not too loud. He felt loud in the beginning because he was so hypophonic, but this was great normal loudness, and boy, did he get that confidence. So let's take a look at the next video. These are the functional phrases, and so let's listen.
How are you?
Hello, hello.
Good job, Joe. Goodbye. Take
Okay.
care.
Goodbye, take care.
Excellent. Nice and loud. Think shout. Thank you very much.
Thank you very much.
Good. Watch me, Joe. Thank you very much.
Thank you very much.
Good. Keep it loud. You focus on me?
Yeah.
Excuse me, please.
Excuse me, please.
Nice job, Joe. Hi, Mom. I love you.
Hi, Mom, I love you.
Good job. What are you doing?
What are you doing?
Good job, Joe. Yes, please.
Yes.
What's going on?
What's going on?
Nice and loud, Joe.
Keep it loud.
What's going on?
What's going on?
Why?
Where
Again.
are we going?
Good, but even louder. Let's go back to why. Say why. That's it. Where are we going?
Where are we going?
Good job.
Wow, that was clear.
I love it. Look at that smile when he said, I love you, Mom. Oh, just to see the parents' reaction. And when he grabbed his ear, he was feeling kind of happy. And I think that was, he saw his mother across the table smiling. It was just such a happy moment. I'm not sure if you saw, but in the video, you may have noticed he also was doing his best to take a deep breath to sustain those productions. And you may have heard me be particularly loud. And what I was doing was modulating my loudness. I got louder to help him reach those normal loudness levels. Then I'll bring myself back down as we continued to work. So he was really one of the first people that I had worked with to break the barriers of autism and build speaking skills in a way that few people thought he could. So when he was asked about his progress in starting the intensive, he used his AAC, that he felt like for years to express his needs was impossible. And he said, now make no mistake, I'm virtually making verbal chatting with my loved ones. So it was a great success. So overall, there were several adaptations to accommodate some difficulties that we initially had with behavior and speech and language disorders. To be able to maintain the LSVT LOUD treatment fidelity, what we did was we had a couple of longer breaks in motor practice. Sometimes we had to go a little bit longer than that hour. We added additional weeks of treatment because he just had such great success and they wanted to keep going and bring that loudness into more and more speech and reading tasks. We did have to modify for his language difficulties and reading level. And I did need to provide a lot of additional feedback, particular kinds of reinforcement consistent with what the behaviorist was recommending, and counseling to increase his confidence as a speaker. But I think these findings provide some exciting preliminary support for intensive voice treatment to improve select aspects of voice and speech functioning for people with autism.
All right. Well, thank you so much, Jessica. I find that absolutely fascinating. And I just love to learn about all the time that you spent with him in therapy, really preparing him and building his strength so that he could receive this intensive treatment. And obviously the outcomes were great. So can't wait to read that article in full.
Thanks,
Thank
Laura.
you. Yeah. All right. So now we're going to shift gears and turn it over to Jennifer Gray. And I'm just looking for you right now, Jennifer. So I can, there you are. I'm just going to shine the spotlight on you so everyone can see you. All right, so really excited for this last segment of our presentation tonight. And to kick it off, just like with Dusty and Jessica, please tell us a little bit about yourself, where you're from, and your work.
I'm Jennifer Gray, and I'm a speech language pathologist. I'm in Denver, Colorado, and I specialize in speech clarity for people with Down syndrome. I'm actually originally from Tucson, Arizona. So what I'm going to talk to you today about is kind of how I, like the other presenters, how I came to LSVT LOUD after really treating people with Down syndrome, and mostly young children with Down syndrome, for almost 15 years. And why it just was, I came to a point where I knew that something was missing. And kind of like the other stories where I found myself just kind of staring at my clients like we're missing it, we're doing everything that the research says to do, we're doing all of our evidence-based treatments, and yet we have many children and adults who the one thing that they wanted most and their parents wanted most for them, which was speech clarity, still seemed out of reach for so many of our people with Down syndrome, and it remains that way today. So that's where I kind of had the motivation to go, you know what, I need to look at this again. Speech is more than articulation and phonology. We know that, but what else is kind of out there? And if you've worked with people with Down syndrome or haven't, for various reasons, we don't have a lot. There's not a lot of research to look at that really tells us what to do clinically. And most of us that are working with people with Down syndrome are in the schools. And so a lot of our focus is on the language, how we give language, how we can make sure that they're learning, especially in an academic setting. But it seems to kind of roll over to everything, is that we just want to improve language and cognition, but we're still left with the same conundrum that we were when they were 2. And so I am going to show a video at the end of an adult that we are currently treating who went through the LSVT program a couple months ago, and his story is kind of neat, and it'll show you kind of how they are the same going from treating very young children to our adults, because the original problem is still there, that original issue of can we sustain voice, can we sustain phonation, and can we speak in longer utterances so that someone who doesn't know me will know and hear what I say instead of how I say it. Okay, so what I found is that most people, when they are either talking to me about Down syndrome or families, we don't know much unless you've really worked with the profession, with the population in our profession. Why is this so difficult? Why is speech kind of the one that just doesn't really get better? Well, as you know, with Down syndrome, they have really unique anatomical and physiological profiles that do lead to a lot of that lack of clarity when they speak. And I think, before now, maybe even just 20 years ago or so, we just kind of accepted that that's the way it was, and this population really wasn't going to get much clearer. Now, there's some reason for that. So they have a higher palate, which means they have a smaller nasal passage, which all that by itself is going to lead to some resonance issues. So we have that hypernasality kind of mixed with hyponasality, mixed with an inability to really control airflow and phonation at the same time. And so even when we manage to fix or help some of the physiological profiles of low tone and dysarthria, we're still kind of left with some things. So what can we do to make a person with Down syndrome as clear as possible? Well, the piece that was missing was that voice and resonance piece. We don't really know how. We don't have a lot of places to go to learn how to teach our young people and our adults how to overcome that and how to speak beyond simple sounds. So most therapists in the schools, because of a lot of what we have to do within IEPs, but really we're teaching speech sounds. We think about, well, okay, wait, what sound are you working on? And what happens is there really isn't the sounds. I ended up kind of looking at our older children and our teens going, they're saying everything right. Even their movements are better. We've come all this way to improve their ability to say this, and yet really when it comes to having a conversation or speaking for any length of time, they are still incredibly difficult to understand. So I found LSVT LOUD, and it really fit for some of these issues that you're going to see here. So in addition to that, the anatomical and physiological pieces, Their vocal characteristics are also quite unique and also very difficult to measure. So it's hard to go out to the literature and say, okay, they all are hoarse or harsh or breathy or speaking too high or too low or too loud, right? I used to tell my clients to not speak as loud because they kind of force and they are kind of harsh with the way they talk. But the problem wasn't loudness, it was that ability to control any output. So whether that be movement with your body or movement of air and sound. And so with that big pushing, really what we were looking at is they don't have a lot of control over that. And so they just kind of go with it. And that in turn brings some issues with pitch, rate, and prosody. And that prosody piece, the more I look at it and think about that today as you see these videos, the prosody is kind of wacky. It's either very monotone where everything gets the same amount of time, or it varies. And simply that rate or that prosody mixed in with a couple of these other things on this page, this is what's really contributing to, what did he just say right there? We heard parts of it, but with all of those other layers on top of simply the sounds or the phonological patterns is really what we're looking at with this population. So it made sense, obviously, to find a way to address that. And so in my personal research, because there's not much out there, I came across LSVT and it fit. And a lot of the reason there is that with childhood apraxia of speech and motor planning, we were already noticing that this was a bigger problem in Down syndrome. I'm old enough to know before that was even a diagnosis of childhood apraxia of speech, we knew that those kids were doing something different beyond just speaking sounds differently, right? We knew that there was that timing piece that wasn't there. And so along with that, we also know that there's some cognitive issues going on and learning issues. And I'll talk a little bit about that, but not very much, only in the sense that their working memory is not very good. So that short-term memory that's usually auditory, so basically listening and repeating or listening and doing, is difficult. And they can't remember a lot for that short amount of time. And so that's, you'll see kind of how the LSVT came into play for me as being almost perfect. And then when I read that a lot of their voice research, really what it showed was that it takes people with Down syndrome almost 2 times, I read 3 somewhere, 2 to 3 times the effort simply to produce voice. So from going to being silent to saying ah is very difficult. And if you have difficulty with that, like you saw in even some of the other videos, what are you going to do? You're either going to barely try or you're going to try really hard. And so where LSVT came into almost perfection for this is with that verbal short-term memory, we knew the cues had to be simple and not too many, and it needed to tell them what to do instead of what not to do, right? Do it slower, do it louder. That's really tough if you have all of the other things going on at the same time. So with loud, do what I do, or use your loud voice makes sense to them. And when you do that, like our other speakers were talking about, all the other things come into play. So we have a reduced rate, we have better articulation, we're able to say the things that we are supposed to say simply by using that one cue. And then for some, we can add in other techniques as needed, like melodic intonation or other things, if they need a little more effort to keep going. I do a lot of telepractice with this population because they are verbal, or they are visual learners and not as much auditory learners. And so because of that, I started to do telepractice with the Down syndrome population because there aren't a lot of specialists. And so I wasn't able to get to families, and families weren't able to get to me, even in just the one state of Colorado. And so telepractice was something I've been doing for a long time. And then obviously around COVID, we were all doing it. So it kind of gave us a beautiful way to say, hey, how well does this really work? And it turns out it does, because they're visual learners. So just quickly, it eases the stress for families to get to therapies, regular therapies, much less intensive therapies that are 4 times a week for 4 weeks. We have fewer cancellations because it's easier to reschedule them. We I was going to say, so I'm going to change it real quick. We knew that it was working with this population. And so when we're trying to figure out what that was, we started creating a lot more visual material. So we have plenty of materials that really allow us to make them as we go and really work on what they are good at. And as we're doing this with our older kids, we found that we were able to incorporate some other things such as the use of technology and being independent with therapy. So you kind of see in a lot of the videos where we know that the parent or someone else is there with them, but then it can be, you know, there but not there. And so it also gives us a way to kind of teach our kids that they can be responsible for their speech as well. And so as we look at LSVT and we have this over practice, that too really plays into this idea of motor planning, because we know that repetition is what helps these children. But the one thing that we don't do is a lot of speech repetition anymore. We do a lot of language, we do a lot of AAC, but by the time a child is 5 years old, their speaking practice is a mere fraction of their peers. And so really the only way to improve speech for this population is to practice, and use it. Okay, so there's my telepractice pitch. This is, I think he is, what is he, 5 years old in this one. He came to me at about 2.5. He'd had a lot of different therapies, very smart kiddo, but really wasn't saying much. He was just kind of moving and destroying and moving and destroying. But when you would, you know, settle him down, it became very clear that he had a lot of skills. We just hadn't tapped into it yet. And so we knew he would be a good candidate for this. And this is not me, but one of my therapists took him on. And something to note about this one is her personality is perfect for this. And he just has to listen to her to keep going. So there's not a lot of visual representation. You'll see how well he does anyway.
My turn. Your turn, Ajax. Nice and loud. Nice job, Ajax. All right, let's do it again. Woo, your turn. Loud.
Loud.
Nice job, Ajax. Just like me. Your turn. Nice job, Ajax.
And so in that video, this is his first week of LSVT, so he's still really learning that. So you see him trying to count with the therapist, trying to guess what she's doing. But you can hear that kind of modulation. He doesn't really know where his voice is, and so he's playing with it and kind of figuring it out. And the person who you hear next to him is his ABA therapist. So we had some issues with behavior because of the speech piece. And it worked really well because he was there to give some of the cues that through teletherapy, maybe it would have been a bit harder. So the next one is going to be starting some of those phrases, and you'll see how this therapist brings him into that. And you get to see his fun little personality come in too, because he's annoyed with her because this is really repetitive and he's not quite sure he likes it yet, but it still works. And together the team is able to kind of bypass those things and really just use it. Okay.
Where are we going to go grocery shopping?
What's that? Where is that?
We're going to go grocery shopping at Whole Foods. Yeah. Can you say that one just like me? Nice and loud. Whole Foods.
Nice and loud.
Nice job. Let's see. Can you tell me to pick one? Pick one, please. Pick one, please. Let's see, what did we find first? Leaves. Oranges. Orange. Nice job. Orange. Orange. Nice job, Ajax. All right. What's next? What do I do? Big one. Okay. We're grocery shopping. We need more fruits. Bananas. Nice job. That was nice and loud. Can you do it again with me? Banana. That was great. Nice and loud.
Please.
All right. What should I do? I'm grocery shopping. One. Okay. We need some more fruits. Apple. Oh, can you tell me nice and loud? Apple. Apple. Nice job.
So what I love about these videos too is you can kind of see that she doesn't stop him and she doesn't correct him for those articulation or phonological issues that he clearly has. But you can see how just being louder actually gets him to clear up his speech. And so it's much simpler this way for those multiple things, because we know that there's 20 things we're really working on all at the same time. So his clarity, and what we see with most kids, is that it improves after the very first session, within the very first session, because they know that simply all they have to do is say it louder and say it again. So it takes away a lot of cognitive issues that they might be worried about, or they're not sure what you're going to do next, right? And so those are those behavioral things that kind of come into play when they're not really sure what's going to happen. That kind of goes away with this therapy. There slows his rate, the longer words. You got to hear a little bit of that rate issue he had with how cute he says banana, but he says banana, and that's pretty common. But we all knew what it was, especially when he said it louder. We also see that self-correction starts to happen, and something we don't read about much either is that people with Down syndrome don't always hear their own errors at all, so they just keep making them unless they're stopped and corrected. But we know that if we stop and correct, we risk some behaviors kind of coming up and self-esteem issues. Well, if we simply tell them how to do it better, we get to bypass that. And hopefully that's kind of what you're seeing in all of these different stories. We're also finding that their MLU is longer because it may not be a language problem. That's not always the case when we want them to say more at a time. A lot of time they don't know how to do that physiologically with breath and control. So once we get from saying bananas to a sentence with bananas in it, all of a sudden our MLU is going up. So that's really fun. We see that self-esteem like you did with the other ones, where all of a sudden, yeah, I can say that, I can do it again. I know I'm not going to be corrected, but I'm just going to get better and better. Family and caretakers knew it was so much easier for them just to tell him what to do. Oh, that was okay, but let's do it again like me, or let's just do it louder. And that is something every family member can handle, and even us as therapists. I have to remind myself all the time, you don't have to say anything else, just that one cue, and let's see what happens. Okay, so this is the adult that we have. This is a newer case for us, but this person is 29 years old, and this is another one of our therapists through teletherapy. He also has autism, and he had really good speech skills when he was younger. Mom contacted me after seeing something about LSVT LOUD and said, I wonder if this can work for him. Can we try it? And of course, yes, we can. And you're gonna see some therapy. This is his current therapist and the person who did it with him. So he just finished a couple months ago, and this is his typical therapy session.
Okay, Brennan, we're gonna practice using our loud voice. Are you ready?
Yes.
Let's start with our easy one. This says, I'm Brennan.
I Brennan.
Good. Let's do it one more time like this.
Okay. I Brennan.
Good. Remember to use your loud voice. Tell me again.
I Brennan.
Good. Even louder.
I Brennan.
Good. One more time.
Hi, Brandon.
Good job. Good job. Okay, next one. How old are you?
I'm 29.
Good. Use that loud voice.
I'm 29.
Good. 2 more times.
I'm 29.
How old are you?
29.
Good job, Brennan. Okay. This next one, our next one is I like the Broncos. Good. Now your turn by yourself.
I like the Broncos.
Nice loud voice. Can you be even louder?
Yeah, I like the Broncos.
Nice job. Okay, 2 times without the words. I like
the Broncos.
Good. One more time.
I like the Broncos.
Good job. Okay.
And so with that video, you got to see a little bit about how we can get it from that 16 seconds of repetition and getting into functional use with questions they might be asked a lot. And then you saw her start to withdraw that visual so that he could just do it auditorily going forward, and how we can, start very scripted and then have that carryover effect.
Awesome. Thanks, Jennifer, for sharing all of that wonderful information on such a population that definitely gets neglected. And so now we're going to wrap up here quickly. So we have a few moments for some questions, just if you're thinking about where do I go and how do I get started. Really, if you are already certified, or therapists who might get certified, what we train is stimulability testing. And ultimately, the decision is based on your assessment, the stimulability testing, which Jessica gave us a wonderful sort of model, and clinical decision making. And if we decide to proceed, maybe immediately or maybe after some trial preparatory treatment, we do a week of trial treatment. If we like what we see, we continue on, we monitor progress, we quantify treatment changes. And if we do decide to proceed, we deliver LSVT per protocol. If you're interested in finding LSVT clinicians who know or have an interest in pediatrics, we do have the Find a Clinician link on our website. Right now for LSVT LOUD, there is actually a pediatric designation. I believe we'll have to start building that in for LSVT BIG in the very near future, but our team in the office will do a lot to try to really help you find and seek out people who are specially trained or specially interested in treating pediatrics. And we also have an upcoming course for LSVT LOUD for kids. So October 21, 22, our virtual live offering, we will be doing the training course for anybody who's interested in learning about LSVT LOUD for kids. So I'll kick it back to Laura, who can wrap it up and will allow us to get to a few questions.
All right. Thank you so much, Cynthia. Just a mention that we have a webinar actually next week that's open to anyone, whether you're LSVT certified or not, on everything you need to know about LSVT LOUD and LSVT BIG, a guide for people with PD and those who support them. So this is really geared towards patients and families. If you have people that would be interested in that topic, please share it with them. They can register at blog.lsvtglobal.com in the events section. So now let's get to some questions, and certainly if you need to go and enjoy the rest of your evening, that's fine. You can also type your question into the survey that will be emailed to you tomorrow, or you can email us directly at info@lsvtglobal.com with your question. If it's for a particular presenter, please let us know that so that we can direct that question to the presenter and get an answer for you. So I'm just going to open up the chat right here and scroll back, and looks like, first of all, presenters, some really positive comments about the videos and your presentation. I think it's really encouraging for us to have this new option for kids. All right, so this one is first for you, Dusty. If you could just clarify strength versus power. And she says, I understand power correlates with bigger movement, but I'm wondering if speed is also a factor.
Yes, and that's what we were trying to achieve. Strength is being able to move against gravity or with weight and that kind of thing, but being able to move with speed and with ballistics, really. So that's where the sit to stand from the floor, sit to stand from the chair came through, really important. That's a more powerful movement. I will sometimes call that functional strength, because it's the things that we need to do when the kids say, I can't play duck, duck, goose because I can't get out of the floor. It takes power to be able to perform that. And so it's not just to be able to do strength, but also to do it with speed.
All right, perfect. I love that clarification. Okay, another question for you. I'm going to keep you on the hook for a minute, Dusty. How many children have you used LSVT with? I know this is relatively new for you, so.
It is. We have used it with 2 other children. Their buy-in and the parent buy-in wasn't as strong as this child's, and so we did see improvements across the board. We did not see 26% improvement in their 6-minute walk test like we did with the child that we discussed here. What we kind of learned from that was we need less confounding variables in there, like school. Being able to do this type of intensive really well within the clinic, and then to go home and do the homework as well. We need less things, as not that education is a distractor, but it makes them tired, right? And so we're saving these types of intensives and scheduling them through the summer and during breaks, because it's a lot easier on the families and it's a lot easier on the children. So we have some coming up in the summer of 2023. We have a child with spastic triplegia that I'm very excited about trying this with, that I think is going to go out really, really well.
Awesome. That's exciting. All right, next question, and this is for you, Cynthia. Is the program 1 hour in session, 4 sessions for 1 month for LSVT BIG and LSVT LOUD?
Yes. So the treatments are 4 days a week, 1 hour each session, and those across those 4 consecutive weeks. That's each for LSVT LOUD and for LSVT BIG.
Okay, great. I have a question, and I'm going to start with you, Dusty, but then if we have time for the other presenters to answer it, I would be curious to know their answer as well. When you're thinking about the pediatric population and intervening with something like LSVT BIG, let's start with, do you see developmentally any kind of sweet spots in their development for utilizing a protocol like this optimally?
For sure. One of the things that helps me determine who I should use it with, the stimulability testing and that kind of thing, for sure. But also, I really need a little bit of that maturity level that can carry over, and they can take tasks and apply them. Sometimes with some of our kids, we have to use more of a floor time approach where we're following their lead, and we can in some of this, but a lot of times we have to have a lot of buy-in from them. I love the early adolescent children, because that neuroplasticity is so high in those kids. And a lot of times with our children with cerebral palsy, with our children with neurogenetic different conditions, just the motor planning itself is tough. And so as we are improving some different motor ranges, we see that carry over with gait and with breaking some of those bad patterns that we've seen in the past. And one other thing I'm excited about, and looking at our children with cerebral palsy and spasticity, is the last time I presented this case was with Whitney out of University of Missouri, and she's seeing in the stroke population that they're improving upper extremity range of motion following this. And it wasn't something necessarily that they were looking for, but it happened. And so with our children that have some spastic upper extremity, and they've done so much therapy, and they're tired of pincer grasp and that kind of stuff. And so if we can see some improvements by doing this type of therapy, I think we'll see a lot more buy-in from the kids and the parents as well.
Okay, thank you so much, Dusty. Let's see, I think there was one that was answered on whether LSVT is individual or group, and it is an individual treatment. During the 1 month, can be group after for maintenance. There is a question here about the BOT2, Dusty. Are goals bought to, or are there specific goals for LSVT?
For her, we use the bot2 just as a measurement tool. We really needed it, to be honest, for our pre-authorization for our insurance. And so since we did it for pre-auth, we did it afterwards to see, because we had so much improvement. We said, you know what, let's give her credit for it. So that's why we chose that. But for her, most of our goals were functional, and being able to get rid of that walker and that stigma when she was around her friends was more valuable than that test score, for sure.
Great, great. Okay, well, I think we're near the end of our hour, and I think the questions have stopped rolling in, but like I said, be sure to email us if you think of other questions, or maybe you want to check out the LSVT Loud for Kids course coming up if you're a speech language pathologist. But as we sign off, I'd just like to give each of the presenters a quick 30 seconds max to just give some final thoughts and recommendations for clinicians that are in our webinar tonight that are working with kids, or maybe thinking about working with kids, and just maybe some thoughts or your biggest tip for them. Dusty, let's start with you.
I think across the board, we don't push patients hard enough. You know, the whole old 3 sets of 10 adage in physical therapy, it's not effective, and pushing people into higher amplitude is where we actually see the functional improvements. And so I love the repetitions, I love the amplitude, and I love the intensive program that LSVT BIG offers these patients. So.
Awesome, that's perfect. Jessica.
I have so many, but I'm going to keep it short. I would say don't sell the kids short. They will surprise the heck out of you. And so if you even have the littlest bit of thought that this might work for your kids, jump in, try it, try the trial week of therapy. It's amazing what results you might get. And then email us about all your other questions, because I have a million other fabulous tips to give you.
Right. I know you really do. I know you do. Okay, Jennifer, I know you have a wealth of knowledge and experience as well, but what's your top tip?
Everything they said, except I think where I really fell in love with it and thought that this was really what I was looking for, is that the self-confidence that came from the repetitions. We tend to think, oh gosh, they're going to be bored, they have to do this however many times, and we're nervous about it and they can't do it, it's an hour, like how are we going to do this? But what we found was that you kind of saw them come here to here, because by 25 or 15 repetitions, they knew they could do it, and then it started to transfer, and that just seeing that confidence is, it'll make you want to do it over and over again.
Yes, yes, I love it. It's intrinsic motivation.
Yes.
Yes.
It's hard.
Yes, yes. All right, and Cynthia, what's your top tip?
Yes, I had one quick comment related to the question you posed to Dusty about, is there a developmental special point? And that is, in one of our papers, we actually looked at characteristics of responders and non-responders. And so there are certain things, and I think the more we do the treatment across the board, we'll get better at that. But, but definitely there are some things that may help us make those decisions. And even just like with Jessica's, if they're a non-responder right now, doesn't mean they won't be a responder a little bit later.
Good point.
But my tip, gosh, I think you said it, Laura, is that intrinsic motivation, and not underestimating that, not bogging down our treatment with external rewards and things that aren't salient, and just dig in with what they love and what they want to do. And it's really quite special.
So throw out the stickers.
Save them from when you absolutely need them, right? Yeah. Yeah. Great.
All right. Well, I just want to say again, thank you to all of you. Thank you for joining us, to all of our attendees. I hope that this has been inspiring to you, and just know that this webinar is being recorded and will be available on demand on the LSVT Global website. You can go to blog.lsvtglobal.com and find it under the on-demand webinars in that blog. If you need help finding that, just reach out to us. And until next time, we'll see you all later. Good night.
Good night.
Good night.